Hi. This is a video on how to remove the heavy oil using small gauge cannula. Many surgeons do not like to use the heavy oil, despite being a good tamponade agent for inferior pathology. Removal of heavy oil can be slightly challenging compared to the removal of the traditional silicone oil. The standard silicone oil floats, therefore removal is fairly easy as it will float upwards. Removal of silicone oil can be done via passive removal or active suction. Whereas for heavy oil, which will fall back on the retina in lying position, will not be coming to the port passively. Hence, for removal, it requires active suction. Important preparations consist of having a well-dilated pupil. If the pupil is small, we may need place sets of iris hook. Well-dilated pupil is important as the maneuver requires very peripheral viewing of the fundus with no interruption until the end. If there is an opacified capsule in the pseudophakic eye, the opacity has been cleared up before we start the procedure. And importantly, to ensure there is no episode of fogging during the procedure, I will prefer to have a gel over the cornea to avoid drying of the surface as well as minimize fogging. This will ensure I will have a good view through the removal process, and importantly with no interruption. Any interruption during the procedure will make the removal of the remaining heavy oil become more difficult. Subsequent step is to have the port placed supratemporally rather than nasally. The reason for this is mainly because we need to have ample space to rotate the eyeball. Positioning the port on the nasal side will not give you much of space for the manipulation as it might be blocked by the nasal bridge. VFC system is being set up at maximum suction. As for constellation, the maximum suction allowed is 650 mm mercury. Once we are ready, place the VFC tip at the supratemporal port. Set the infusion bottle height at 15 to 20 mm mercury at the beginning. Gently press down the tip and make sure it is embedded in the heavy oil, not on the surface or above the oil. You can see, we can even visualize the ciliary processes in this case because of the indentation. Once we are ready to aspirate the oil, bottle height is increased to 50 to 60 mm mercury to prevent eyeball collapsing during the procedure. Active suction is activated and you can slowly see the oil is coming towards the tip inside the eye. Concurrently, get your assistant to look into the syringe that you used for suction. Ensure there is clear oil coming into the syringe and not blood or water. If you accidentally aspirate fluid rather than oil, the assistant will see very fast filling of the syringe, which should not happen. Aspiration of oil will fill up the syringe very slowly and not too fast. With continuation of active aspiration, we can imagine the level of oil is getting less inside the eye. Therefore, be prepared to slowly rotate the eyeball to ensure the aspiration tip is always in contact or within the heavy oil throughout the whole procedure. Make sure to continue the suction at all time and never let loose of the oil. This is an example if you accidentally lost contact with the oil. The oil will sink down. With the short metal tip, we will not be able to reach the oil if the globule is too small. Luckily in this case, the oil globule was still big and we are able to reposition the tip within the oil to continue the aspiration. Slowly you will see the edge of the oil in view funduscopically. Continue the active aspiration, keep aspirating until the size of the globule becomes small as 2 to 3 disc diameter size. Then slowly lift up the oil and bring back the eye into normal position. And towards the end, control the vacuum suction slowly to prevent sudden collapse of the eyeball towards the end. Any remaining small bubble of oil behind can be aspirated with the cutter or soft tip. Thank you.